Call Health Committee meeting to order. Stand and have the invocation. Father, thank you for today. Thank you for privilege of being here. We thank you for the healthcare personnel that treat our citizens and do so in such a meaningful way. And we're thankful for each and every one of them because they have a great task in front of them to render treatment. We're thankful for the resources that the tribe is able to provide our citizens in order to get a state of wellness. Father, we pray the next hour or so that we use our insight and wisdom to make the proper decisions. In Jesus' name I pray. Amen. Shelley, roll call, please.
Yes, sir. Mike Dobbins.
Here.
Dora Petzkowski. Here. Keith Austin. Danny Callison. Here. Julia Coates. Here. Sean Crittenden. Here. Joe Deere. Rex Jordan. Johnny Kidwell. Here. Darrell Legg. Here. Wes Snowfire. Joshua Sam. Here. Mike Shambaugh. Here. Melvina Shotpouch. E.O. Smith. Here. Condessa Teehee. Victoria Vasquez. We have a quorum.
Thanks, Shelley. Hope you've had a chance to review the minutes. If so, I entertain a motion to approve the minutes. Second. All those in favor? Aye. Any opposed? Motion passes. Moving down to reports. Claremore Service Unit, Mr. George Valyard. Thanks for coming, George.
Good afternoon.
Good afternoon.
Should have my report there. It's for the month of December. In that month, we did 2,353 COVID tests. And again, the largest group of positives is the age 20 to 29-year-olds, with 30 to 39-year-olds right behind those. The visits are going well. Dental's going well. She checked for me before I left. Again, they've scheduled 8 to 10 appointments every day for each one of those staff dentists. So that's going well. At the end of December, we had the Claremore Employee Awards ceremony was held there in town. It's where we give out, we recognize staff there from the hospital for their work and efforts throughout the year. That's a pretty big deal. We have that downtown and invite families and everybody, relatives, to come down and be part of that. And then finally, I want to brag a little bit on our emergency room, Claremore Indian Hospital ER. It's now accredited by the ACEP Geriatric Emergency Department Accreditation Program. ACEP is American College of Emergency Physicians. Accreditation provides an excellent avenue to convey to your patients, colleagues, and hospital administration that your program is first rate and meets the interdisciplinary generic standards set forth by the American College of Emergency Physicians. We were just awarded that last week, so real proud of the emergency room down there. They do a lot of work. Any questions?
Questions for George? Do you have an urgent care there as well as an ER?
No, sir. Everybody comes through ER.
Okay. All right. No inquiring minds today, huh, for George? All right. Thank you, George.
Thank you.
Dr. Steve Jones, Cherokee Nation Health Services Director.
Good afternoon.
Hello.
Well, I don't have a lot of of information to give you for myself today. I do have the report that's in your packet, and if you have any questions, I'd be glad to answer those. I do have two guests with me today. I have Dr. Hughes with who is the medical director of our urgent care and ER, to talk about, as you asked last time, to bring someone in to talk a little bit about our stroke-ready certification. So she'll be giving you a little information on that and answering a few questions. Then I also have the Senior Director of Behavioral Health, Julie Skinner, and we had several questions about our harm reduction recent openings. So I wanted to bring her in. If you have any questions for her, she's going to give you a little short rundown about it, and then have questions for her with your permission, Mr. Chair.
Sure.
Do you have any questions for me about the report or anything that I can answer for you before I have them come forward?
Johnny?
Hey, Doug Jones, I
Yeah.
appreciate you being here today. And also, I know I've been flooding your email with quite a few things. A lot of information went out about the navigators that are, and people are just, man, they have so many questions about that, and not necessarily wanting their services, actually wanting to be helpful to the Cherokee Nation and connecting with those people and expanding that like a force multiplier, so that works out well. I just have one thing for you. I was looking at some of the budget mods that were coming in for our next DNF. Are you going to be around later? Could you stay after? And I'd like to talk about that offline if you wouldn't mind.
Absolutely.
All right,
Yeah.
thanks, sir.
Thank you.
Okay, Dr. Jones?
All right, well, I'm going to have Dr. Hughes come up first and give you some information about the stroke program, okay?
Good afternoon.
Good afternoon.
Thanks for inviting me to speak on the very important subject of strokes. So strokes are a second leading cause of death and the third leading cause of disability globally. 87% of all strokes are caused by blood clot to the brain, or what we call an ischemic stroke. The other 13% are caused by bleeding in the brain or hemorrhagic stroke. When we take care of stroke patients, we say time is brain, air quotes, but it's really not. Time really is brain. 1.9 million neurons are lost every minute that a stroke continues. There is a medication that can be given to patients that have a stroke if they present quick enough to the emergency department. This medication is a thrombolytic. It has the ability to go and break a blood clot up and stop a stroke in progress and actually reverse a lot of the symptoms of a stroke. It's really amazing to watch this medication work. The American Heart Association has set a threshold of medication administration in the emergency department within the first 60 minutes of a patient's arrival to the emergency department. So there was a recent study that showed that only 30% of patients presenting to emergency departments actually receive the medication within that 60-minute time frame. In 2019, we started looking at our own stroke data, and well, you don't know what you don't know till you really look at it. And what we found was that our time of medication administration was actually 93 minutes, which is not acceptable. So we really started to work on our processes of stroke patients and care of stroke patients. We became an acute stroke-ready hospital in 2020, and in 2021, we had decreased that 93 minutes down to 59 minutes. And in 2022, we've decreased that even further down to 49 minutes. And our fastest door to medication administration was 19 minutes. And it was actually when we were being inspected. So the inspector that was coming to certify us as a primary stroke center got to see our team in action. So it was good stuff. So an acute stroke-ready hospital, I mentioned that earlier, is a hospital that is demonstrated the ability to diagnose a stroke and timely treat a stroke with that thrombolytic medication that can dissolve the clot. They then have to transfer the patient for their inpatient care at either a primary or comprehensive stroke center. Hastings became an acute stroke-ready hospital in 2020, and then we were recertified in 2021. Now, a primary stroke center has met all everything that acute stroke-ready hospital meets, all the guidelines, but also demonstrates the ability to take care of the inpatient, the admitted stroke patient, which requires a multidisciplinary team of neurologists, hospitalists, speech pathologists, occupational therapists, physical therapists, specially trained nursing staff to care for that patient whenever they are admitted. Hastings was given the designation of a primary stroke center in 2022 in November when we were inspected for the first time. We're pretty proud of that. It's pretty unusual for a hospital our size to achieve such a designation. This was actually the best news, though, for our patients, because our patients no longer have to be sent up the road over an hour away from their family, their caregivers, and their support system. And I humbly think that we take the best care of our patients, so we get to keep them right at home with us. Is there any questions for me? Yes,
Okay,
ma'am.
Go ahead, Danny.
Sir?
Yes, ma'am. Is the city hospital here, are they certified as well, or are we the only ones in Tahlequah and in this area?
Yeah, great question. So they are certified as an acute stroke ready hospital, but they are not a primary stroke center. The closest primary stroke center is St. Francis Muskogee is a primary, and then after that, you're looking at Northwest Arkansas and Tulsa hospitals as being primary and comprehensive.
So Dr. Hughes, before we became stroke ready, what were our patients' options if they were experiencing a stroke? They walk into our ER.
So we would still treat them, and we were treating them, but when you become certified, you're then obligated to report all your times to a database, and then those times and those records are open whenever they come and inspect you. So it's not required to report your data until you become certified. And so our patients still received the same treatment, but I can't say that it was as timely as it is now. I mean, you can look at the times and you know that our emphasis and our improvement in our processes have really spoke volumes for the timeliness of that treatment.
So approximately how many stroke patients do we see a month, just on average?
I would love to answer that, and I can for sure email you that data.
Okay.
I don't have that. It's kind of hard to query the electronic health system, so that's a lot of manual extrapolation. It is quite a few patients that we do see, and it's certainly saved a lot of transfers. That this is all brand new. I mean, this was just November, and by the time we got word, it was late November. So this is all really new of keeping these patients, but I'll be happy to share that if you would like.
Sure, I appreciate. Well, you cited how important or how timely it is for treatment for the stroke patient. Before, if we were having to transport them to St. Francis Muskogee, even that's 45 minutes. You emphasized if it's done within 49 minutes, I guess the odds improve immensely. But this is a game changer that we have
It
a
is.
stroke treatment center for our citizens.
Yes, sir, it is.
Because normally a stroke in rural Oklahoma, its prognosis not good.
Yep.
Even if you somewhat recover, you're going to have all kinds of residual effects, obviously.
You're correct.
Wes?
Hey, I appreciate you coming in today. I know that there's probably a lot of anomalies on what causes strokes, but do we have a calculation on what maybe underlying conditions that we're seeing in our clinics relating to the lead up to a stroke?
So I don't have any data on that, but we know that a lot of our patients are higher risk for strokes because we have a higher incidence of diabetes, heart disease, kidney disease, hypertension, hyperlipidemia, the risk factors for stroke. We have higher incidence in our population.
Yeah, is there anything with that stroke center, since we've been identified as that, being able to work with our public health back here to be able to try to continually address those underlying issues, so that way we prevent the aspect before we have to step in here with this?
I love that idea. There's not currently, but that is a great idea.
Okay, great.
Yeah.
If there's anything, I know she's sitting back there, she's been a great help, Ms. Pivick, on public health, and I'm sure that something like that could corroborate and be great. So appreciate you coming in today. Thank
Yeah.
you. Thank you, Chair.
Victoria?
Yes, thank you. I have sort of a selfish question because both of my parents passed away with complications from strokes. And I do live in the rural part of Craig County, in the northernmost part. A drive from our ranch to the closest hospital at Miami or Veneta is over 30 minutes. And if you got a helicopter ride to somewhere that could treat a stroke, I'm concerned about the time that we don't have Hastings closer to where I live. I don't live close to Hastings, and as a lot of Cherokees in the northern end of the district. So how could I find out, A, I didn't understand the name of the medication you talked about, and B, how can I find out which hospitals, like St. Francis and Veneta, if they're stroke-ready or certified? And I would like more information about that.
Okay, I'd be happy to look that up and let you know where the closest facility is to your area.
Okay?
Yeah, because I don't know right off the top of my head if Anita is or not.
Okay, and could you tell me about that medication you were talking about? Because I didn't hear,
Sure.
couldn't hear you.
So the name of it is tenecteplase, or what we call TPA, because we're all very simple. And that is a medication that's given intravenously. We try to give it as early as possible, but we also have to do things like do a CT scan to make sure there's no bleeding in the brain, because it can cause bleeding. And sometimes we have to check some simple labs before administering that medication. So there's some steps to take before that medication is administered. And then it's given intravenously. We give a bolus, and then it goes over an hour. And then we closely monitor that patient during that administration, and then for the 24 hours after, and then, through their whole hospital stay, but it's pretty intense monitoring of that patient to watch for any complications.
Thank you. Thank you, Chair.
Junior?
Say you live 30 miles from here. When you call an ambulance, are they able to do anything? Or they just have to wait till they get here?
So they play a big, important part, and that's the fact that they alert us. So we actually set off the stroke alert whenever that ambulance is en route to get the team all assembled before you even get there. They're checking a blood sugar. It's important for us to know that before we push this medication. They're obtaining an EKG. They're obtaining vital signs. We have to treat blood pressure that's high before giving this medication. If they tell us the blood pressure's high, we sometimes give them orders to get that down before the patient gets there, so that saves us time whenever you get there from having to lower your blood pressure. So they're an important key part of the team is the ambulance crew. Mm-hmm.
Ma'am, you were talking about the time, 90 minutes,
Mm-hmm.
and you've been able to get it down quite a bit. How long has someone been working towards that, like here, to get our numbers down? It's been a lot longer than the time that we received the certification. Is that a fact, fair statement? That-
So 2019 is when we really started looking at our data, and stroke care is always evolving, and so 2019 is kind of whenever we went, okay, let's see where we're at, and that's whenever it was a big eye-opener that we needed to change the way that we treat stroke patients. And so as we started to hone in on our processes, that's whenever we started looking at what does it mean to be acute stroke ready, and how do we achieve that certification, and then after that, the primary stroke certification. So, yeah, it was a year and a half before we got the certification of getting our processes in place so that when we got inspected, that we were proud of our data.
Well, that don't, sometimes stuff like that don't make the headlines or the billboards, but great work. I mean, we've been living our lives, doing our jobs, while you guys, folks like you, have been behind the scenes improving our process, and that is simply helping our people. So thank you for not only what's going on now, but everything that led up to where we are now. So thank you.
Thank you. I appreciate
that,
that.
Doctor. And
It's a whole team. I can't take credit for it. It is a whole team that makes this happen.
And
Danny?
Lisa, if you don't mind, a little bit later, if we could, I know that there's been some preemptive steps, like Wes was mentioning. I know, like in my district, there's buildings going up, and, you see it across the nation, the preemptive stuff that would go hand in hand with that stuff. If you don't mind maybe mentioning a few of those programs and things that we have sometime today, I'd appreciate hearing about those. Thank you, man. Thank you, Chair.
Go ahead, Danny.
With us being primary, when the new hospital is built, will we have rehabilitation capabilities at the new hospital? I know Hillcrest and Tulsa is one that, after everything gets calmed down, you go back to try to get your functions back. Will we be able to do that at our new hospital, or will this be something we'll have to contract out as well?
Are you talking like for inpatient rehab or?
Yes,
or-
yes. Once
Okay.
once you've got them back on their feet, if there's any complications from the stroke, I know that, I've had family members where we've had to send them to Hillcrest, and I didn't know if that was going to be part of the new hospital or not.
We're evaluating all those possibilities. I can't tell you for sure that that's going to be a part of it or not at this point, because it's the square footage and what is going to serve the most people, because there's a lot of different aspects of that we're being asked to evaluate. So I can't tell you an answer on that absolute yet, but I will tell you that we're evaluating that currently.
Dora?
Yes, this certification is extremely impressive. I'm proud of you all. I was curious, on the recertification, how often is that to be done in order to keep your certification?
It'll be annual.
Annual, thank you.
Mike?
Yeah, this is a wonderful program. I don't know if I asked this last time or if I wasn't paying attention, but did you say how many beds we would have in the stroke ward?
In the new facility, we're going to have 125 beds is total.
Wow.
How those will be divvied up, I can't give you an absolute number on that yet, because, a portion will be med-surg, there'll be labor and delivery, there'll be different areas that we'll have beds in, but it's 3 times what we have now. So the hospital will serve 3 times as many people.
So I'm just talking about just stroke beds. How many do you have ballpark?
I don't know the answer to that yet, because a lot of it depends on how that program evolves, whether or not we're going to do rehab and things of that nature.
Right.
So we're still working through that process.
And I assume that, rehab is a process and it takes time. Is it maybe something you could do where initially your rehab could be there and then you could contract I think that's the way it works right now in a lot of places, especially our smaller clinics aren't big enough because they have rehab just for normal injuries and different things like that. And then you start throwing these kind of, injuries that need to be rehabbed. It takes time. So you'll probably contract out with different places in different communities, depending where you live, if they have those type of facilities. Is that something?
That's currently what we do, and Dr. Hughes mentioned the interdisciplinary team. So we have physical therapists, occupational therapists, speech therapists, things of that nature already integrated into the team. So the initial aspect of the rehab starts in inpatient. Now, it has to be continued once they're discharged, but yes, currently we are contracting out for those services and trying to keep patients close to their home.
Well, that's exciting. I mean, that's something that's been needed here a lot, especially because of the diabetes situation. So that's great news.
Okay. Well, Dr. Hughes, most of us represent the rural communities and our rural clinics. What do our rural clinics do to kind of try to help stabilize that patient as best they can? What are they equipped to do? I know Tahlequah is where the stroke center is. What about our personnel in these outer clinics?
Well, typically, we don't have that present to us unless it's an emergent situation where someone just pulls into our parking lot. And that has happened in the past, especially with someone having a heart attack or something of that nature. At that point, we activate the 911 emergency system. And as Dr. Hughes said, then the communication starts. The EMS system they know where the stroke-ready hospitals are, what's closest to them, and that starts the process. So sometimes you may not be brought to us because there may be another one that's closer to where you have that incident. So.
Okay. Is that accessible to the list of the stroke-ready hospitals on our reservation?
I made a note of that, and I'll get the information out for you. I don't know for sure what all that list is, but I made a note, and we'll try to get that information out of what's located on our reservation and the adjoining counties around us.
Councilor Vasquez just raised the issue where she lives. It's a long ways.
Yep.
And if she knows where those are, that would be helpful. Thank you.
Yeah, absolutely.
Any other questions? Dr. Hughes? Thank you, Dr. Hughes.
Thank you.
All right, I'm going to go ahead and have Ms. Skinner come up and give you some information on our harm reduction program.
Good afternoon. So as many of you all know, our harm reduction program started late last year. We actually opened our doors on September 26th. Our first year goal for harm reduction, there's many different interventions that we wanted to launch with our harm reduction program. So those of you who know about harm reduction, it's a way of getting connection to people who are involved, who are people who are using drugs or injecting drugs. And so with harm reduction, our goal is to reduce hepatitis C, reduce HIV. We're there to try to connect individuals to services as well. And one of the things that we started 3 years ago was our MAT clinic, which is our medication-assisted treatment, which also is a form of harm reduction. I'm not sure how much your knowledge is of our MAT program, but based off the work that we did with MAT, we knew that the harm reduction expansion needed to occur pretty quickly because we were seeing a lot of patients coming in who had a lot of challenges, and they had a lot of problems with intravenous drug use. They were having infections. They were encountering secondary problems from their drug use that needed immediate attention. And so part of the goal for our Safe Syringe program that we recently launched is that they're going to connect services for those people. And we're already seeing that. Our first year goal was to reach 75 people with our harm reduction program. We're already at 98, and that was a couple of weeks ago. So we know that by word of mouth and how people are finding out in our communities, they're coming to our fixed site location. Our goal in the next few months is to launch our mobile site, which will be going out into the communities, offering these these services as well, such as the Safe Syringe. We also are going to be offering peer recovery support specialists, other services. We're also launching our intensive outpatient services, which is part of our harm reduction is to provide a service for those folks who are maybe stepping down or stepping into intensive inpatient. And so the intensive outpatient allows you to, like, after you get out of inpatient, there's a gap there, right? There's a gap that's like very much needed because, after you get out of inpatient, it's hard to almost, go back into your community safely so that you're not going to want to be using again. So our IOP services as part of our harm reduction is to go in there and help with providing those services for those folks who are stepping out of inpatient. So currently, we're ramping up. We're getting staff on board. We're going to have outreach workers. We have already one PRSS already on board, and we're going to have our point of care testing also at our fixed site location as well to test for those HIV and hepatitis C as well. Let me know if you have any other questions, and if there's more information you're needing.
Questions for Ms. Skinner? Victoria?
Yes, thank you for being here. And it was interesting that you talked about you're going to launch a mobile unit.
Yes.
Will that be sent throughout the reservation to clinics on a calendar basis, or how will that work?
Yes, we're going to be sending it into the communities. It may not necessarily be at the clinics, but we are going to be able to go into locations. We're working with our community partners right now to establish locations. We haven't yet got the schedule yet ready. But yes, that's something we're partnering with right now, is finding great locations for this mobile clinic.
Great. Thank you. Thank you.
Okay. Daryl?
Hey, Julie. The last time that y'all were here, I asked the question about the being able to hire a felon that has his LPC, that's certified through the state, if he was going to be able to work in our adult treatment facilities. Have y'all found out yet if that's going to be possible?
I definitely think so. The LPC, it's going to be based off HR. They're the ones that are going to have to do the background checks, and they tell us if they're able to come on board. But if they have a license, the state of Oklahoma, through whether it's an LCSW, an LADC, if it's an LPC, those licenses monitor that every year. So every time you renew, you have to give them that information if you've been arrested or had any legal problems. And then you'll lose your license if you have anything criminally pending against you that you haven't taken care of. So if he has a license, that's a good sign. But I can't speak for human resources and how they would see that.
Wes?
This is just kind of a question of more understanding, because I know this is a federal grant project, right?
Yes, we have two funding sources for this project.
Yeah, one is, I've kind of just come from the old school thought, obviously my family's been in behavioral health it's just kind of been our family's work for our whole life. But On addicts, how are they coming in to apply to get syringes? I mean, how's that process going to work? They come in and they say they're addicted and they need syringes, and they fill out a form and they get those syringes. Well, what's the process going to be like?
Yes, they come into the clinic, our fixed site location, and they're going to meet with a PRSS, a peer recovery support specialist, someone who's been through it. And our first goal is to build the rapport. Welcome, talk to us what's going on, why are you coming in today? And they reach out and they talk to us about their situation. We're not going to pry, we're not going to really ask a whole lot of questions and see what they want to talk to us about. We let them lead that conversation. But then we fill out a form that's a non-identification number, so they have a membership ID, so that way they can come back in and present their ID and we can give them their syringes. But we start out with the starter kit, and the starter kit, gives only a certain percentage of the syringes, and then they have to come back in the next week. And our goal is to get them to keep coming back, building the rapport, because we know that if you have a safe syringe program in your community, you're 5 times more likely to go to rehab, to get help, to get services, because you form that connection. So our goal there is forming that connection and getting them to come back.
Where else has these type of programs worked at to where we can look up their success rate?
One of the places we toured was the Eastern Band of Cherokee, North Carolina. We went out there to their program and got to tour their site, and they have the mobile as well as the fixed site location as well, and they also are within their clinics. And so they have been doing this for a few years now and have had great success with it. Another place is up in Duwala is in Washington. It's a tribe up there that has been doing this for years, too, the Lumbee tribe. And we have partnered with them on learning how to do different things that they have done that have really going to be able to help us here as well.
Okay, so we partnered with the Lumbee tribe on that one. I guess just it's a new thing for me. It's hard for me to grasp concept of, because I'm afraid of what prevents those syringes making into other hands. It's definitely, I like the idea and the concept behind it. I can get behind that. It's just there's always this, what are the outside effects? What are the problems that can come out of this whenever we're supplying these kinds of syringes and uses to people who are already drug addicted, and that might spread in the community. And I get that we're trying to bring that in so we can try to fix the problem. So it's, like I said, it's a unique concept for me, especially new to the area. A lot of people, may have concerns in my district about that, preventing that from being able to escape one person's hand and go into another person's hand to continue driving that force of drug problems that we're seeing in the area.
Yeah, you bring up very good points. So one of the points is, how do you keep this from spreading and
Right.
things like that? So infectious diseases is running rampant within our populations for people who inject drugs. It's rampant. Hep C, HIV, I don't know if you've ever paid attention to those infectious diseases numbers, especially in this community. That is very, very, very huge concern. And we know that these types of programs drop those rates by 50% very quickly. And so for those rates, these folks are already using these drugs and they're sharing needles. And that's what we were finding out in our MAP program, why they were having these infections and they were passing there's diseases back and forth. And so that was one of the reasons that really prompted us to move forward and to develop a program like this so that we can really start to hit that. And we're bringing these syringes back in because as these 98 folks are coming back, we have 126 visits from them. So those people are coming back and they're bringing back their needles. And so we want to be a site that they know that they can bring back needles as well.
So is that a requirement that if they get 10 syringes, they have to bring those 10 syringes back before they get 10 more?
Yes, as we give them a starter pack and then we have them come back and bring their needles. Yes, they do have to bring back their needles.
Okay, that's good. That's kind of one of those checks and balances I was looking for, so that way, it doesn't, like I said, doesn't expand the umbrella of drug users to where, like I said, we have a person come in, they're getting those syringes. Are those making it back out and then connecting 4 or 5 other new drug users that now we do have to supply those with syringes as well? So I guess, is there a study on that to show that under this environment, we not only reduce the spread of infectious diseases by wrongful use of or reusing of syringes and needles, but does it actually, is there a case study on this program to where it actually stops and starts to dwindle the spread of drugs in the community?
Yes, we do know there's several projects out there that have done research around the needle issue like having needles in the community. It does reduce needles in the community because part of the goal is, they're bringing them back to us. We always have partners within our communities that we know if you see needles in your park, we know those folks can go out there and pick them up. And so it's just getting more communication and awareness around what programs are out there and how to get those back out of our community.
Yeah, I know you said needles there, but I mean, far as like overall drug use in the area.
Drug use, so
Is there a
that's
study on that where it goes down?
Yes, we know that 5 times more likely if you have a Safe Fringe program in your community, those folks are going to go to rehab. That's our bridge. It's part of our continuum of care for recovery. So it's like the part of the American Society of Addiction Medicine has a lot of research around this. And so that's why we wanted to go, this is like 0.5 of the ASAM levels of care. And it's the early part because there's a section of people who are not ready to go inpatient. And if we keep ignoring the problem, we're going to continue to have infectious diseases, our drugs are going to continue to grow. So our goal is to get in there really early and build that rapport so these people can overcome a lot of these challenges that they're facing with addiction that they have a place to come to.
I understand. I just didn't know how much this was, if there was a study that had already shown that this program reduces overall drug users in the area. And since we don't have that yet, that was just my question and concern if they had one.
Yeah, I can definitely get that research for you.
If we could get that and get that sent over to where it shows that in this area, say we know over in Eastern Bend they have this there, over the past 2 years, we went from a 5% user rate in the community now that there's only 2.5% user rate of drugs in the area. So something like that would be helpful. So, all right, appreciate it. Appreciate it, Speaker, or Chair.
Sean?
Yeah, it's exciting, the program for us here, the relationship you were talking about building. I think we're unique here where other entities may not have when you sit down and visit, they may not have have you looked at our career services department? You're visiting with this person. I'm sure part of that conversation would be letting them know that there is a rehab program when they get ready, right? And like I say, I think we're in a unique situation. We could tell them about the program Daryl and Matt Lamont, reentry, we could tell them about that. We can say, hey, if you ever get ready to really get serious about this, we have the rehab. We've got a career services department. We've got somebody that can, when you get back, maybe help you with some clothes or a little money. I think it's all going to go hand in hand, and it's exciting to think of just how many of our people will be helped. And tragically, I don't know of anybody that's not touched by this. Not naming any names, but I've been. Just people real close. So it's exciting to see how, and I like the relation. It puts it was neat to hear from me because you hear about, giving out needles, giving out syringe, that has a negative connotation to it sometimes. Like we're just going out past them and, hey, enjoy. But if we can make that relationship and offer them some of the programs we've already had, it's exciting, and I appreciate what you guys are doing.
Yeah, and I thank you for bringing that up. Family care management is part of the program, so we have those outreach workers and those PRSSs who are doing what you're saying. They're providing housing, and they're getting them connected to career services. And yes, we are definitely partnering with our other folks within the tribe, for sure.
Keith?
I really appreciate this effort. It seems to me like you're building a bridge to the folks, and hopefully they come back across that bridge when they need to, when they are ready. I had a question about, are we serving people who enter? Do they have to be beneficiaries?
We're serving everyone.
Okay, I'm glad to hear that because everyone's affecting the communities. Yes. Anytime you deal with something like this, you have a liability that you've built into something, to these kind of interactions. How do we deal with that liability legally?
The law, the tribal code, gives us the ability to provide these services. And we also have developed and written and approved all of our harm reduction policies that talk about how we're going to serve individuals and what our procedures are going to be in those areas.
Perfect. Well, I'm really glad we've studied this, and I'm excited to see how it starts affecting our population more positively. Thank you.
Danny?
Yes, ma'am. A couple of things we might get out there. You and I had visited the last council meeting and went home and did some reading and studying. We're not going to provide a place, by giving these needles, we're not providing a place for these people to come in and use their drugs.
No.
And there is some programs out there with that, and my understanding, we were not doing that. Number two, we have yet to mention the fact that by using these needles, our first responders, are they not kind of at risk when they're not this way of getting that, the hep and the HIV and the different things that goes along with the dirty needles?
We know that when these types of programs get launched, that actually starts to decrease the risk for first responders when you have a needle program, a syringe program in your community. So they're going to definitely see that.
Thank you.
Johnny?
Thank you, Chair. Ma'am, I really appreciate you providing that information. I think the needle, the syringe exchange program is important for any number of reasons, all of which we've all discussed here. It's interesting, that just for everyone's edification, that there's about, I think, 43 states in the U.S. have some sort of needle exchange program, and if I'm not mistaken, that includes Oklahoma, which signed that in, I believe, the summer of 2021 or so to do a 5-year program with that. So, man, I appreciate the effort and coming online with all that. I think it makes a big difference, and hopefully we'll get some longitudinal studies to see just how much of a difference, but appreciate all your work on it. Thank you. Thank you, Chair.
Wes?
Just one quick question. I know that this is considered paraphernalia. Our drug codes, I'm not sure exactly how that lines up with them. Is this something that they're able to get by with? So that way we're not supplying them with something and then they go out not using at the time, but they have it on said person, get pulled over and consider drug paraphernalia, and now they're picked up for something that we ultimately supplied them with. I didn't know if that's something we need to correct on our criminal codes or how that's working with law enforcement.
Okay, let me address that. So I want to give you a little background. This has been years in the making. If you remember, some of you were on the council at the time, we started a hepatitis C elimination program. And the part of those steps was a harm reduction program, which wasn't even possible at the time. Number one, because of our codes, and number two, because of the state codes and state laws around that. So in the last few years, that avenue has been opened through legislation with the state and legislation inside of our own codes. So yes, those have been addressed. We didn't start this program without buy-in from the community. We worked with law enforcement to acknowledge that this was going on. They are supportive of this. That's why there's a registration process that these individuals, when they come into our facilities, that they get. And that card, if they have that card, that will let law enforcement know that they are in a harm reduction program. So we do work with local law enforcement. That's part of the mobile unit too, is identifying those communities that are ready to work with us on this and making that possible. This is the first, and we plan on expanding this program to allow more citizens and more communities to have access to it, because there is research that shows not only do you make that connection, but you also reduce infectious disease. And that was where this all started from. And there is research that shows where harm reduction programs make an impact and help you eliminate infectious disease in your communities. So it doesn't affect just Cherokee citizens. This affects everyone in the community, as Councilor Critton had said. It affects us all, myself included. So so it is a good program, and it's one of those things that a lot of education needs to go on it. That's why I want Julie to come and talk to you today a little bit. There's more education going to be coming out about it. We'll get you some information on the infectious disease part of it to show how that is impacting. And those results are all over the country. They're not just ours.
Perfect, thanks, appreciate that. And now, is that a database that the law enforcement has, or are the patient has to have that card on them?
That card right now, yeah.
Okay, all right, appreciate it.
Mike?
I guess you could even say that those needles are prescribed to them in a way. It's almost like a prescription in a way. That doesn't necessarily mean that people don't abuse. It doesn't matter, what it is in life. If somebody wants to abuse it, they'll abuse it. But the good that comes out of it, overshadows the bad. Because, you're talking about, if you're talking about an addict, you're probably talking about somebody who does not want to come into the clinic, even if they're sick or whatever. But this might give them the opportunity to, when they do come in, and they do build a relationship, it would serve as a bridge between us and them as far as them getting health care.
Absolutely.
So, yeah, that's a big, I mean, go ahead, I'm sorry.
Yeah,
to cut you.
absolutely, and that's part of this program too, is giving that direct access. So one of the things that we're working on is having those, that our harm reduction team is an advocate for those patients. So if they have dental needs, that we give them the resources, that we get them into the dental clinic and address those acute needs. Build that confidence, build that trust, so that when they are ready to receive treatment and receive help, that they trust us to give them that help without the stigma that goes along with it. So it's about building those relationships, and it's the first step out there to bridge that divide.
Yeah. That's innovative, and, who would have thought, that type of program could be successful, but, it's proven that it is, so I'm glad that we're getting on board. All right, thank you.
Thank you.
Dora?
So I'm just reiterating here, the card is basically the equivalent to a doctor-prescribed syringe.
No, I wouldn't go that far. I would just say that it lets law enforcement know that they're enrolled, or they're especially here in Cherokee County, that they're enrolled in the program, or they're a member of the program. Now, if they're breaking the law, they're not going to get out
Sure.
of jail free card.
Sure.
It is just to let them know if they have syringes, which are considered paraphernalia, that they're in a program that's working with them to move forward. Now, it'll be up to that law enforcement personnel to make the decision on what happens from that point. But it is something that gives them a little bit more of a advocate on their part, that they are trying to move
Right.
forward with their life.
And so as long as they are not acting disrespectfully with these syringes, they are not considered paraphernalia.
That would be more of a legal question to ask, but I would to answer. But I would say it gives them an opportunity to show that there's a reason they have those syringes, that they're part of this harm reduction program. But it does not give them a get out of jail free card.
Right.
If they have drugs on them, or they're doing something else illegal, it's not a free pass.
Okay. Well, I fully support what you're doing. Thank you.
Junior?
One of the good things about that 10 is at least they'll bring them back and they won't be in our parks and our lake areas and everything. I'm excited about that. And, so will the vans or whatever, will that be a regular route all the time, or same day they be, say, in Salisaw?
We're still developing that, but Julie, you might want to speak to that if you have.
Yes, we're going to definitely have a schedule, so folks will know where to go on what days, for sure.
I think, everything I read about it, it's always worked, so, I mean, it's a lot better than it is, so. And I'm still excited about this morning. I thought that was a great presentation.
Well, thank you.
Thank you.
Any other questions for Julie? Thank you, Dr. Jones. Thank you, Julie. Lisa? Cherokee Nation Public Health Director Lisa Pivek.
Good afternoon. Thank you for having me today. It's good to see all of you. In the interest of time, so that you can move to your next committee meetings, you have my report in front of you. 2 or 3 things I wanted to highlight. This past week, Deputy Chief Warner and myself were in Atlanta for the Tribal Advisory Committee meetings at CDC, and worked diligently throughout the week. He does a great job of advocating for direct funding to tribes from CDC, for technical assistance for tribes from CDC, as well as the flexibility to exercise self-determination in how we utilize those funds and how we develop programs that are specific to our communities. During that time, we got to hear about CDC's reorganization of the centers, institutes, and offices. We did have a chance to give direct comments to Dr. Walensky, the director of CDC. We talked about additional partnerships, and we had lots of presentations on CDC's data modernization projects within tribes. Just to speak briefly to some of the points that Councilor Crittenden asked me to speak to, we did submit this last Friday, another application to CDC competing with states for a school health funding that will help us to implement nutrition and more physical activity programs within schools if we are awarded. We're also piloting a performance management system still. Last month I talked about all WINGS participants being able to, right now, you have to use your phone and a QR code to be able to provide feedback on their experiences. We have expanded that to WIC now, in doing a pilot with anywhere that WIC touches a participant, they can do a survey instantly, customer satisfaction. These are things that are going to help us improve the uptake of the smoking cessation programs, our physical activity nutrition programs, all of the things that we offer in communities that maybe sometimes citizens don't take advantage of, and that is because maybe we need to figure out better ways to administer them, better places to administer them, what they like about them, what they don't like about them, where they would suit them best, and so we're in that process right now. We do work closely with the with Health's Diabetes Prevention Program and offering the DPP program to participants that qualify, they meet the clinical conditions. We're also looking at another program that we could administer similar to DPP, where you don't have to meet the clinical indicators to be involved in that. And of course, if you think about what we do, if you think about whether it be with substance abuse or stroke, all of those things leading up from birth to the grave, you think about WICs touching mothers, breastfeeding, touching children and mothers, all the way through school-age children, looking at all the programs we have available for our adults in communities, expanding the WINGS program by using that information we're getting back from the citizens. As Councilor Crittenden mentioned, the building of facilities that can help increase physical activity in communities, and all the way down to our community health workers who work closely with most elders and trying to connect them with services and resources that are needed. So, having said that, we're also working on the farmers markets that will touch everywhere from WIC participants to school-age children for the summer EBT program, and then this year, of course, the seniors farmer market program. So I'm happy to field any questions.
Dora?
Yes, Lisa, I just wanted to say thank you to you and your department. Your report is filled with a wealth of effort to address the underlying problems for the stroke victims that we spoke of earlier, and I just wanted to say thank you.
Thank you. I'll pass that on to our staff. Thank you so much.
Sean?
Just a quick comment. Thank you, Lisa. Kind of didn't mean to. I kind of put you on the spot there, didn't I?
That's fine.
But that was a really beautiful talk you just gave, so thank you for doing that, and I appreciate all your public health work. Thank you.
Thank you.
Lisa, on your report, it just states official application for reaccreditation accepted by PHAB.
Yeah, the Public Health Accreditation Board.
So it's just been submitted, hadn't been approved yet?
No, so they're in the process of, so they do everything online now.
Yeah.
They don't do any actual site visits to sites anymore. Pre-pandemic, they did, and they've instituted a new online system. That's why there's the holdup why we haven't. But we've received communication that they're reviewing our application, and pretty quickly we'll do our online review.
So that's a pretty big deal, isn't it?
It is. We will be, once reaccredited, we'll be the first tribe to be reaccredited.
Yeah.
So.
Thought that was worth noting. Any other questions for Lisa? Thank you, Lisa.
Thank you.
Okay, I see no old business pending or new business pending. I see an announcement. Before we make that, notice our March calendar was in flux. Shelley, when is March Health scheduled? At 1. Okay, so next meeting then would be tentatively scheduled for Monday, March 13th at 1 o'clock. I need one more motion.